Hello everyone. Thanks for tuning into our presentation. My name is Meghna and today I will be talking about our work titled The Human Air Interface Responding to Poor Air Quality Through Lived Experience and Digital Information. This work was done as a part of my undergraduate thesis in collaboration with Dr. Grace Eden at the Department of Human-Centered Design at IIIT Delhi. Air pollution is a major public health concern impacting billions of people across the globe. According to the World Health Organization, 9 out of 10 people breathe air containing high level of pollutants, leading to approximately 8 million lives lost annually. More than 90% of these, however, occur in the low and middle income countries located mainly in Asia and Africa. In India, there are about 1.67 million deaths every year due to the effects of air pollution, where levels of particulate matter concentration often reaches 15 times the safe levels. 8 out of 10 most polluted cities in the world are Indian cities. The national capital region, Delhi, ranks on average the sixth most polluted city in the world. Air pollution is a serious environmental hazard that we as ethnographers cannot solve. However, we do have the capacity and the responsibility to reflect upon how technologies are designed to communicate the environmental risk to the public. The Air Quality Index, also called the AQI, is a set of numerical and color-coded indicators used to communicate current as well as forecast air quality. There is a lot of data packed into the AQI chart and its associated digital visualizations, which can often lead to difficulties in understanding its content. In addition, such information might quickly lose its relevance in context where embodied knowing and local knowledge and practices take precedence over scientific indicators and numbers. To acquire a deeper understanding of how people living in Delhi access their personal risks around air pollution and the safety measures they take to mitigate that risk, we conducted 23 semi-structured interviews followed by walkthroughs and discussions of 3 air quality monitoring interfaces. We recruited participants across 2 neighborhoods in Delhi, a high-resource neighborhood and a low-resource neighborhood. The interviews focused on understanding people's experiences and attitudes towards air quality, whereas the interface walkthroughs focused on understanding how AQI visualizations and related air quality information was understood by our participants. We will now discuss the key themes that emerged from the interviews and interface walkthrough discussions with our participants, specifically their experiences with air quality and how they made sense of air quality information. We found that most people in both communities understood the term, however, from different vantage points. For example, one resident of the high resource community described air pollution as some particles called gun are mixed in the air along with smoke from various places, which pollute the air. This is called air pollution. In the low resource community, however, air pollution was associated more with its perceived after effects, such as smoke from firecrackers during Diwali, an Indian festival, and smells from industrial smoke in the neighborhood. The differences between the two communities in their conceptualization of air pollution reveals the differences in access to educational resources. Moreover, our participants primarily identified the presence of air pollution using visual and olfactory indicators. As P02 recollects, there's darkness all around and my throat becomes sore. It feels like the smoke is getting inside my body. There is also an itching sensation in the eyes and I feel anxious. We found that these encounters often led to feelings of suffocation and anxiety among our participants, as well as led to additional stress of protecting themselves and their loved ones, affecting our participants' overall emotional well-being. When it comes to managing their health and well-being and protecting themselves, we found that our participants turned to a variety of measures, including conventional ones such as masks and air purifiers, as well as traditional practices rooted in the deep sociocultural histories of the country. Many participants from the high resource communities said that they had used a mask while a few said that they tried using face masks but do not use them regularly since they don't like wearing them or perceive them to be not effective against air pollution after using them for a few times. Participants in the low resource communities, however, use chunnis like scarves or handkerchiefs to protect themselves. Affordability was a key concern that governed participants' protective measures and choices. Participants across both communities reported using spices and herbal condiments such as tulsi and jaggery as immunity boosters. In addition to discussing with participants how they manage their relationship with air quality on a day-to-day basis and their hopes for the future, we also wanted to know how they made sense of air quality information to better understand how the two might be related. We now discuss our findings from the interface walkthrough sessions where we asked participants to explain how they interpreted AQI visualizations across three digital air quality interfaces, namely Air Visual, Air Matters, and the CPCB Web Bulletin. First, when asked, how do you understand air quality index? Most from high resource community described the AQI as a number that represents the pollution level in the air. However, they lack detailed knowledge of what the metric represented and how it is calculated. For instance, P22 said, "It keeps coming on TV and news. What's there to understand in this? It just says how much the quality of air should be and how many times worse it currently is than the normal value. I don't have much idea about the number, but they say it should be 2.5, which means that the air quality here is really bad." This quote implies a misunderstanding between AQI and PM 2.5. With so much complex data displayed, it can be easy to misinterpret its meaning. None of the participants from the low-income community understood the index when it was shown to them. In fact, they had never seen it before. When asked their first impressions of the air quality on seeing the interfaces, several participants noticed the face icon in the Air Visual application. Interestingly, they did not refer to any other associated information such as AQI number or color. However, we observed that participants had difficulty in understanding AQI illustrations which were not representative of their context. For instance, a few participants were not able to interpret the meaning of a full face mask. They said they had never seen anything like this before. In addition, we found that the granular data such as maps and charts was of limited interest and in turn overwhelmed the participants. Some participants even felt anxious seeing the large amount of data. Rather, most participants just wanted to know how and when to protect themselves. We also observed disparities between health advisories provided and our participants' personal lived experiences. For instance, P01 said, "We don't have windows in such small houses like ours." Lack of culturally relevant representations posed difficulties when trying to pose difficulties to participants when they try to interpret the meanings. In order to improve the interpretability of air quality interfaces for the Indian context, we suggest design implications and opportunities for technology-mediated interventions that could improve the risk communication and raise awareness of the causes and effects of air pollution. First, pairing numerical data such as AQI with familiar sensations. For example, adding representations of the sky that changes color from blue to dark gray as seen and experienced. In addition, we suggest that icons could be designed to more accurately reflect the cultural context in different countries. For example, using familiar objects like chunnis instead of full face mask icon. As we found in the study, many participants preferred to use traditional protective measures against air pollutions such as CADA rather than conventional ones such as masks and air purifiers, including those who could afford to buy these products. An important question here to consider for future research could be how might multiple and sometimes competing knowledges coexist in visual design and what impacts it could have on health. Lastly, displaying the sources of air pollution And predictions of improved air quality, if these polluting factors were eliminated, could also help in participants realizing their agency to minimize and protect themselves from air pollution. To know more about our design recommendations and findings, we invite you to read our paper. Thanks for joining. Thank you.